drops, the easiest response in the world is to reach over and turn up the flow meter. But what if the real problem isn't the oxygen level at all? What if it's the tubing, the mask, or the reservoir bag, or a blocked entrainment port? Before you touch anything, you need a way to think this through systematically. And that's what we're building in this video. Every time you're choosing a device or deciding whether to change one, you're really asking three questions: the purpose, the patient, and performance. Purpose comes first. What's the oxygenation goal for this patient? And what FiO2 do they actually need to get there? Sometimes the goal is simple: nudge a stable patient's oxygen up a few points. Other times it's urgent: get a severely hypoxic patient's saturation up right now and safely. Purpose sets the target, everything else has to hit. Patient is next, and this is where you actually look at the person in front of you. How severe is their hypoxia and what's causing it? How old are they? Are they conscious and able to cooperate? Do they already have a tracheal airway in place? Any facial trauma that will rule out a mask? Are they breathing through their nose or are they breathing through their mouth? That last one matters more than it sounds. A nasal cannula depends on a patient actually breathing through their nose, and a committed mouth breather may not get anywhere near that FiO2 you're expecting. And is their ventilation stable, or are they working hard to breathe right now? Performance is the device side of the equation. What FiO2 and flow can this device actually deliver, and does it hold up against the patient's inspiratory demand? Does it stay steady if their breathing pattern changes, or does it drift? Is it comfortable enough that they'll actually tolerate it? Because a device a patient keeps pulling off isn't delivering anything at all. And can this particular patient use it safely, given everything you just found out in the patient assessment? Run through all three: the purpose, the patient, and the performance. Now, here's a habit I want you to build early. A falling SpO2 does not automatically mean turn up that oxygen. Let's walk through why. Say a patient is on 40% air entrainment mask and you notice their SpO2 started to drop. Before you touch that flow meter, there are two things you check: the patient and the equipment, right? On the patient side, look at the SpO2 trend. Is this a real sustainable drop or a brief dip that's already recovering? Check their respiratory rate and their work of breathing. Check on mental status and skin color. Are they comfortable? How do they look overall beyond just the number on the monitor? Then comes your equipment check, and it matters just as much. Work through the system in order. Check the source and the regulator. Check the flow meter. Check the tubing and the connections. Check the mask position. Has it shifted? If there's a reservoir bag, is it doing what it should? Check any valves and check for downstream obstructions. Anything past the flow meter that could be blocking flow, including the air entrainment port itself. In our example, that's exactly where the problem is hiding. The entrainment port is partly covered by bed linen. With less room air getting pulled in, what this patient is actually receiving has changed. And you never will catch it if you jump straight into increasing the flow instead of checking that equipment first. Reassessment is not optional. You check the patient and the system again to confirm the change actually worked. You don't just put them on something and walk off and pray that they're good. Two more habits to lock in. First, a patient having COPD is never by itself a reason to withhold oxygen. We always treat hypoxia. Titrate to the prescribed target and reassess their ventilation as you go. And second, a safety note on transtracheal oxygen: if the catheter isn't delivering the way it should, mucus obstruction is a common culprit here. Assess the patient and the system. So here's a question to sit with before we head into lab. Before you change devices, what exactly should you check on the patient and what should you check on the oxygen system? That question is really the entire framework brought together. Define the FiO2 target based on the oxygenation goal. Confirm total flow is actually adequate for this patient's inspiratory demand, not just adequate on paper. Select the interface that matches their age, airway, their breathing pattern, and clinical condition. And then reassess. Check SpO2, work of breathing, and comfort. And then titrate to the lowest FiO2 possible that gets the job done. The right device is the one that matches the goal, the patient, and the performance you actually need, and then matches what you observe once their therapy is running. Selection isn't finished the moment you pick a device off the wall, it's finished once you reassess and confirm it actually worked for this patient. Notice something about everything we just covered. Every one of those checks happens before you ever touch the flow meter.